Hi, good afternoon everybody. Welcome to this July meeting of Derby's Health and Wellbeing Board. I have one apology from Richard Hudson. I imagine you have others, Lindsay?
Yes, I have a few. Another from Councillor Wright, Robin Jewis, but Richard Martin is here to cover, Sue Ann Lim, Kathy McLean, Claire Mabani, but we've got Brian Barber to cover, Giz Robinson, Nav Sahota, Andy Smith, Gamel's covering, and Rebecca Webster, Alison Wynne, and Jim Austin, where Kim Broadhurst is covering.
Thank you, Lindsay. We don't have any late items, but just to say that the Health Watch item has been withdrawn for now. So we'll have a little bit more time to discuss some of the other items if we need it. Any declarations of interest? And I'll just take a silence or a nod as acceptance of the minutes of the May meeting 26. Yes, thank you very much everyone. So just very quickly then going to the Health and Wellbeing Board Action Plan. On page 3 there, I see that we could have had ostensibly, we should have had a report today on the benefits for health of climate action. So we don't have that, but it is something we are actively working on and discussing. I know that, and recently Dr. Jewis and I have been initiating a project to create cool spaces in the city, for example. So, I mean, that's just one aspect of what we're dealing with. It's a huge report with lots of actions, and I'm very keen to see those actions pushed through, and I know Dr. Jewis is, so it is in progress, as it says, but we will get a report hopefully fairly soon on that. The only other point I would like to raise, and it's just a note, I mean, it's probably not something we can resolve now, but just as I was looking at this morning, this action plan, I think this is perhaps might be a problem for the ICB, Alex, because I got an invitation by email this morning for a health day organised by Derbyshire County Council with all health partners, and inviting myself, no doubt a few others in the room, for exactly the same date, Thursday the 10th of September, that we have earmarked our development session to look at neighbourhood health plans. So just to register that, so we'll have to sort that out perhaps with Alison when she comes back. But I mean, I would imagine that would pose as too much of a demand on the current staff for the ICB, I imagine. Is it?
Yeah, thanks for flagging that, Councillor Martin. Yeah, let's definitely sort that out because we've had that date in for this authority and this board for quite some time, haven't we? So I was brought up to, you accept your first invitation and decline the subsequent one, so we'll have to work that through, yeah. Thank you.
Thank you. It's probably just indicative of the kind of lapse in some of our integrated meetings since we've given this long anticipated demise of the ICPs. I think there's been a bit of a crossover, but we will get that sorted. And thanks for confirming that, Alex, because just to register that, I don't see, it's not reasonable to expect the ICB to be able to manage both of those meetings simultaneously, and thanks for that. So let's move on very quickly then to our first item, a really extensive report on Derby and Derbyshire oral health strategy, and we've got Alan Reid and Sarah Busby are going to present. Thank you.
Hi, thank you so much. And good morning, everybody. My name is Sarah Busby. I'm a public health registrar. I currently work at Derbyshire County Council and the University of Nottingham. Within this particular context, I was responsible for coordinating the Derby and Derbyshire oral health strategy. And I do quite deliberately use that term coordinating because, as you'll see in the presentation, it was very much a collaborative effort. we've wanted to bring the strategy to this board today for to share the work that we've done and the work that went behind the strategy, but also to specifically ask if members of the Health and Wellbeing Board would serve in the governance structure for this particular strategy. Next slide, please. So before I talk about the strategy itself, I just wanted to give a little bit of context as to why we felt it was really important that we had a local oral health strategy. And this is a quote that was taken from a recent Health Watch report, and I'll just read it out. It says, "Since lockdown ended, I've been trying to find a dentist accepting new NHS patients. Unfortunately, no result. Since then, the condition of my teeth has deteriorated rapidly. 4 of my teeth are cracked, flush with the gums, with further holes visible to the naked eye, bleeding gums and recurring jaw pain that prevents me from functioning normally. I have to blend most of my meals because I can't chew them." And I think what this quote does in quite a powerful way is it shows quite clearly how difficult these situations are for people and how significantly poor oral health can impact our basic daily needs. Next slide, please. And for us, it's really important that we take a step back and think, actually, how is it that people end up in such difficult and desperate situations? And when we're talking about oral health, it is quite multifactorial. So many of us will be familiar with some of those individual factors, such as making sure we're brushing our teeth regularly. But there are also some wider societal, political, and economic factors, what we would refer to as upstream factors, that can have a significant impact on our oral health as well. And this diagram here you can look at in more detail in the strategy document itself, but I wanted to include it here for 2 reasons. First of all, it demonstrates that actually when we're talking about things that are good for oral health, these things are also generally speaking good for our general health as well. And an example of that is reduction or avoidance of tobacco, alcohol, substance use and high sugar diets. But it also shows that actually, if it was just one organisation in Derby and Derbyshire trying to manage these issues, it would be incredibly difficult. And from this, we knew that not only did we need an oral health strategy, but actually we specifically needed a systems strategy if we were going to work most effectively to address some of these issues. Next slide, please. So that's what we did. You can see on the slide a list of some of the key organisations that were involved in the strategy development. And if you go to the next slide, when I say involved in the strategy development, I mean involved in every aspect of it. So right from phase 1, which was our planning phase, all the way through to phase 4, which is where we are now in our strategy implementation phase. In terms of our next steps, what we're currently doing is we are in the process of finalising our more detailed action plan. We're finalising and formalising our strategic oversight. And we're trying to share the strategy as widely as possible. So this is our proposed strategic oversight. You can see in the centre of the slide, we have our oversight group. So this is a core group of stakeholders that will be looking at the strategy as a whole. At the bottom of the slide are some examples, it's not an exhaustive list, of organisations and groups that will be involved in some of those more detailed actions. But we also knew it was important to have a layer of accountability. So we've already presented this to the ICB Primary Care Subgroup and the Derbyshire Health and Wellbeing Board, who've agreed to act as part of the governance structure. And as I mentioned, this is also why we're bringing it here today, because we would like to continue to reflect that systems ownership of this strategy. So just moving on to the strategy itself. Unfortunately, in the interest of time, I can't go through the details of the strategy, but I'll just give you an overview of some of the key points. So our overall vision is to improve oral health in Derby and Derbyshire and reduce inequalities in oral health. In the centre of our summary diagram on the slide, you can see labelled 1 to 5 are 5 areas of focus. And on the outside, we have our 5 cross-cutting themes. So these are themes that we want to think about in all of our areas of focus. Next slide, please. So our 5 cross-cutting themes include adopting a life course approach, which just recognises that actually over the course of somebody's life we'll have different risk factors and protective factors. We want to reduce oral health inequalities, whereby health inequalities are avoidable and unfair disadvantages between groups of people. We want to make sure we're using evidence and contributing to the evidence through robust evaluation, for example. We want to focus on improving oral health literacy, which is an individual's ability to understand their own health and navigate the health system, and we want to continue to work together as a system. So moving on to our areas of focus, our first area of focus is access. And by access, I'm referring to people getting to the right support and services for their oral health issues. It's probably one of the most widely publicised issues when we talk about oral health, so we knew it was really important to integrate this into our strategy. So for each of our areas of focus, we have our 5 steps. And when we're talking about access, we've recommended that we set a minimum standard for access for general primary care dentistry, so your typical dentist you would see on a high street, within each neighbourhood, and ensuring that we commission to that minimum standard. But we also recognise that actually there will be some areas and specific populations that might need additional support or more specialist support as well. And finally, we want to work with the services that we already commission to try to increase the capacity through national recommendations. Next slide. Our second area of focus is prevention. So by prevention, I'm referring to preventing oral health issues. And in our 5 steps, we outline the importance of using evidence-based prevention to the right people at the right time. And this includes increasing the reach of our prevention initiatives through connecting with different settings, but also really solidifying our training offer to health and social care staff. And then we also want to focus on some of those upstream interventions and work with colleagues to address issues around social and lifestyle causes as well. Our third area of focus is supporting the dental workforce. So this really centres on improving our engagement with the workforce and making sure that they're represented properly in our discussions and meetings. We want to use this engagement to shape our initiatives aimed at recruitment and retention. And we also want to practically support our workforce, for example, ensuring that they all have access to the right occupational health services. Fourthly, integration of oral health and general health. And our 5 steps here really focus on closer collaboration and better alignment of oral health and general health actions and work streams. This sort of reflects the point that I made at the beginning, which is, actually the mouth isn't separate from our body. It is a window into a person's overall health, and it's significantly influenced by our physical health, mental health, and well-being. So close collaboration is essential, really. And then finally, working with the public. So our 5 steps are focused on improving engagement, and this includes general engagement with the public, but also targeted engagement to specific communities or high-risk groups. We want to foster a 2-way communication with the public and use that to co-design methods of, for example, addressing those issues around oral health literacy. And then finally, this is just to signpost you to these list of 5 statements in the strategy. And these statements were originally developed by our colleagues in NHS Midlands, and they essentially describe what good would look like for the people of Derby and Derbyshire. So just encourage people to have a look at that if you haven't had a chance yet. I appreciate that's a very quick whistle-stop tour of quite a big document, so I'm very happy to take any questions or comments.
Thank you, Sarah. I mean, that was a real executive summary of a very detailed and comprehensive report. So, thank you. I mean, there's lots of really interesting facts in the report and factors, and so there is a lot to look at. So, I'd encourage people to look at the report, particularly in terms of thinking about what different organisations can do to support this. But Councillor Hazelgrave.
Thank you, Doctor, to you and your team for producing a really accessible report and breaking it down to nice stages that we can follow. Just on the prevention theme, I'm Cabinet Member for Children and Young People, and I'm sure you know about our family hubs in Derby, which may not be replicated completely in the same way in Derbyshire. but is a really strong presence right across the city, and particularly focused on areas of greater deprivation. And clearly, I would assume that our family hubs are really into this and making sure even at the antenatal stage when they meet mothers or mothers-to-be, they're talking about babies' oral health, obviously when they start teething, but also that their milk teeth are as important as their second set of teeth in terms of forming habits which will hopefully endure even through adolescence. Yeah. Yes. So I'm hoping that all our family hubs have that support behind them, and that's part of the kind of feature when somebody comes through the door for the first time, whatever age their child is, but also obviously at that antenatal and postnatal stage as well. But thanks ever so much. And there are all sorts of factors clearly in terms of oral health, not relating to diet, which could be liquid, solid, or in between, and how much sugar is in, etc., all that kind of thing. And parents need to be taught about that because children will be attracted. It's like a drug to them, isn't it? Let's face it. So hopefully that advice will be taken on board by parents. The only other thing, I'm also responsible for looked after children. I would assume our look after children get at least an annual checkup, 100% compliance, and if there are gaps, that we take steps to actually make sure that their teeth are, and obviously they see a dentist regularly.
Yeah, thank you so much. Really helpful. I think what part of what you're saying as well is again bringing that integration of oral health and general health as well, just recognising that actually there are these opportunities for oral health prevention in our sort of wider health and social care system, which is one of the things that we would really encourage and reflect in our strategy. And on top of that, highlights the importance of making sure that we are training our health and social care staff appropriately in prevention initiatives so that we can use each of these interactions with people to really offer that prevention. Specific to the looked after children, I believe that there is a specific pathway, but I would need to look into that in more detail. But yeah, thank you.
Sarah, would you mind turning your mic off when you're not speaking? Thanks, because it affects the pickup on everybody else's.
Have I done that properly? Okay. No.
Thank you. Any other comment? Councillor Kerr.
I really endorse the idea of teeth just being part of one's rest of one's body, and I think that's really helpful. The other thing that the full, you didn't mention, but the wider strategy highlights is the frequency of needing to go and have your oral health checked. And that seems not to be flexible at all. I have to positively say, look, you're not doing anything on my teeth. You don't need to see you. I'll tell you if there's anything happening in between. And it just increases the capacity of the dental service if people aren't going and paying for a checkup that they don't need. And I don't know what more we can do to enable people to tell their dentist they don't need to go and see them so often. I think people, if the dentist's receptionist has said, come back in 6 months, it's very difficult to turn around and say, actually, I don't want to see you in 6 months. I'd like to come back in 9 months or 12 months. And I think there's an education thing there that maybe you're planning to include. The other thing I was really surprised not to find mentioned in this report at all was vitamin D. Because research, and there's been more recent research in the last 5 years, looking at vitamin D and the role in not just general health, but also both in the formation of teeth and the healthy teeth, and also the maintenance of healthy teeth. So is there a particular reason why that hasn't been drawn out in this report?
So just to take the the first point was around frequency. Yes, sorry. Yeah, thank you for raising that. There is national recommendations around increasing the sorry, I'm not looking at you just so I can talk to my mic. Yeah, around increasing what we would call the recall interval. So the frequency in which you're seeing your dentist, and there is national recommendations about increasing that for certain groups of people. And that comes into one part of the strategy, the fifth step of increasing our access, one of those recommendations around increasing the capacity of services. So it's absolutely a really important point to bring in. The second point around vitamin D, I think because this particular report is quite high level, it's difficult sometimes to go into a lot of the detail of specific actions that we can take. I absolutely see your point, and I think that again partly would come into that integration of oral health and general health side of things, and I can certainly flag it to the team doing the action plan as something to look into.
Please do. Thank you. Councillor Ashby.
Thank you, Chair. Thank you for the report. It's really good and important that we're keeping this whole topic at the forefront of attention, really. Obviously, from the quote you shared at the beginning, we're really well aware that there's a terrible backlog of people with huge dental problems. How do we feel we're doing in Derby City and Derbyshire in terms of really tackling the problems and getting on top of the backlog and making sure that, one of the aims there was making sure that people could access dental health care where and when and they needed it and in a place that they could access. Where are we up to with all of that?
Yeah, it's really devastating, the situation that people are in, and some of these challenges are really deep-rooted. There might not necessarily be a quick fix that we can offer to some of these issues. The dental services are commissioned currently by our colleagues in the ICB. They've been a core part of our stakeholder group, and they are taking responsibility for a lot of those initiatives around access. They were heavily involved in making sure that the plan that we designed was sort of realistic for them, and they've said that that they could deliver that in terms of setting a minimum standard for access within each neighbourhood. We do have to be respectful of some of the wider changes that are going on in the healthcare system with that though as well, which could add some additional complications. But I do think also it's really important when we're talking about these issues that we also talk about prevention, because there's almost two parts of it, isn't there? There's, ensuring people can get to the right treatment for the issues that they're already having, but also stopping people from having these issues in the first place. And I think when we talk about oral health, it's really easy to only focus on that access part of things, isn't it? But in some ways, to ensure that we're stopping these issues completely, we also need to have that strand of prevention all the way through there. I agree. There is deep-rooted problems, but we're at the start, and we're hoping the strategy will make the difference. With
regards to prevention, I had meant to put a second part of what I was going to say, which was, it's a long time since I've looked at the baby red books and all of those sorts of things, but do we have enough information going in? Right at the beginning, I know Councillor Hasselgrave also spoke about that early prevention, but, in the Red Book so that when parents are filling in when they have their teeth, they're also seeing, now they've got teeth, this is what you need to be doing for the whole of their life health that's ahead of them. But also, I'm sure Councillor Martin will remember, when we had our children, you got this bag of goodies before you left the hospital with all sorts of things, Sudocrem and disposable nappies and baby wash and baby cream and things. Do we have, if such a thing still exists, what about toothbrushes and toothpaste and, stuff that makes people think, oh yeah, this is something that's also part of this journey? Because I'm passionate about the prevention side of it. I saw too many children in general practice with dreadful dental problems already and dreadful drinking and eating habits already.
Yeah, so there are some prevention initiatives that we already sort of commission and deliver. And one of those is the delivery of toothbrushing packs, and that does go out to, I can't remember the exact population, but it is specifically delivered to groups of people with the aim that, you know, people should have, you know, the basics. They should be given a toothbrush and toothpaste. We also offer some additional prevention initiatives, things like supervised toothbrushing in specific areas where there are high levels of deprivation, to make sure that those good habits are formed as well. So there is some of that prevention work that does go on. I believe also it is quite a core part of that health visitor education connection with new mothers as well.
So just following on from that, thank you. I mean, the report is really comprehensive and very extensive, and there's a lot of detail there about the state in Derby, which is in some ways, in some aspects, doing worse than other parts of Derbyshire, I notice, and etc. But the picture across Derbyshire is very uneven as well, as we know. I would like to, so, and obviously we do agree that prevention is really important, but of course, I think historically it's the dentist who's been giving people the most advice on oral health. I mean, my dentist, frankly, anecdotally, is the only person who talks to me about my teeth and oral health. Nobody else ever does, which is perhaps peculiar to me, but the dentist is still a really critical point of contact for people in relation to oral health and especially for children. And we know that for many years now we've had a two-tier service with dentistry, and I think this report is brilliant. It doesn't hide any of that. It doesn't hide the problems, and it just importantly bring to the fore some of the voices of people, and the frustrations they're expressing are very, very familiar, and that nevertheless still inability to access the dentist is critical for two reasons. One, that motivation to keep looking after your oral health often comes from a visit to the dentist. Secondly, you know, frankly, I mean, perhaps I'm fortunate, but for me, the tooth pain is the worst pain I've ever experienced, and I have two children. So I often say that, but it's true. One born at home, so that was it, you know, absolutely. It's the worst, for me, it's been the worst person pain I personally have suffered. Other people will have suffered other pain, no doubt, that's worse than the pain I suffered. But the point is, it's pretty awful. It's totally debilitating, actually. So my point is that access to a dentist is still really critical, and we know that people can't access a dentist easily, or we know that a few years ago, because we looked at it in the scrutiny committee, a lot of dentists at that point in Derby were actually just discontinuing their NHS patients, and we know that was to do with the contract. A lot of that was to do with the NHS contract, and so I suppose there's a couple of points I'd make, is that I see in here you refer to, I'm not sure if there's a new national contract or whether we've just got a new contract here in Derbyshire, but there is a reference to a contract and a new contract. So I just wondered if you could say a bit more about that and how that's going, because that was seen as the critical block to more and better NHS dentist access. And the only other point I would make, and it's slightly related to this, is that on page 12, you say that, you know, you refer to the fact that private dentistry services are found, but they operate as private business, so they can't update any activity from them. Now, I totally understand that, but given the fact that we've got a two-tier service, and given the fact that many people are forced into private dentistry or were just obliged to enter it, the overall picture will be very skewed by not actually acknowledging the work of private dentists. For all that I'm obviously an advocate of NHS dentistry, but the overall picture is critically determined now by what the private dentists are doing, isn't it?
Yeah, thank you. So just on the first point, do you have any more update on the national dental changes bit?
So the existing contract from 2006 still stands. What there is been a series of updates to that contract to encourage improved access. I can't give you the exact figures on that, but more access to emergency treatment and more units of activity. One of the big problems with the contract was in relation to restorative work, so routine fillings, extractions and root treatments, which were given all scored at 3 units of activity. Of course, when you worked in a really deprived area where those treatments were much higher, you might have a patient requiring 10 fillings, 3 root treatments, and you'd only get 3 units of activity, the same as someone in a less deprived area where the usual treatment would maybe 1 touch-up of a small filling. So, so there was some adjustment of parity to that in deprived areas, but essentially the contract, as I understand it, still remains. So there's just been some national tweaking in terms of local ability to change the contract. There's an offer to offer more UDAs and to commission more UDAs for or units of dental activity for other practices to encourage more access to NHS.
So do we know whether there's adjustments to the basic contract, which dentists themselves were totally rejecting en masse? Do we know whether that's having any beneficial effect in improving some access to NHS dentistry?
No. So I think it is. It's quite the issue with recruitment and retention of dental staff is quite complicated. Specific to the contract, there haven't been significant changes to be able to know if that's had an effect on that particular issue. I think, and it comes into your point about private dentistry as well. I think we need that engagement with our dental staff, because we need to work with them to understand how we can practically offer solutions that would encourage them to stay locally, that would be different from the alternative of becoming a private dentist. Because there are things that dental staff want, and from initial conversations, opportunities to support research programs, for example, or portfolio diversification is something that we can offer, or we might be able to offer locally, which perhaps the private dental world might not be. But it is very difficult for us to get any data from private businesses. But we are able to get some dental data through the National Dental Epidemiological Programme survey, and that would come from the population in Derbyshire. We regularly commission that, and we have recommended that we continue to commission that as well.
So in essence, it's that with WELTS we can respect all those activities, and we very much, I personally do respect the strategy and the focus on prevention and the broader issues, obviously. In terms of access, which is really, what's exercising the population really, primarily, it's a job for Yvette Cooper to pick up, ideally, to tackle this contract issue, root and branch, sorry for the pun there. Oh dear, that was a very poor pun as well. Rather than, it's still I'm not going to use a metaphor, it's still a problem that needs to be addressed fundamentally. Okay, and obviously I realise it's beyond the powers of anyone locally, including the ICB, to address that. Okay, thank you. Thank you, yeah. I'm not sure you have your mic on, actually, sorry.
I'm just wondering, in your writing of the strategy, if you have had an opportunity to identify the areas that do the worst in terms of access to the dental services, and to determine what the reasons why those areas are doing worse off than other areas. I live in Cheshire. In my local town, we haven't got access to, we haven't got any NHS dental care. We access it in private dentists. So I suspect that if you got used to the fact that it is privately provided, you may not be able to access that if you think that there will be a payment involved. So the question is identify the areas where there's a lack of access, the proximity of those areas to NHS dental care.
Thank you very much. I'm just facing this way so I can talk into the mic. We do have some data available, and all of that is included in the strategy document. What I would say is it's very high-level data, and when you're talking about access, it's important that we make clear that we are able to give information on the amount of treatments that people are having, but we are not able to say conclusively that, you know, who isn't going to the dentist, if that makes sense. We can't fully capture with the data we have at the moment unmet need. And it's something we talked a lot about when we were developing the strategy, the limitations of the data that we routinely have, which is important and good, but for questions of access, it does leave that question around unmet need. This is why we thought it especially important that we be looking at access and commissioning levels of access on a neighbourhood level, because on a smaller footprint, it's much easier to understand questions of unmet need. So to some degree, yes, but I wouldn't want to say conclusively we understand that question around unmet need.
Thank you. Thank you very much. Do partners want to reflect on how they can practically assist the goals and aims of this strategy as well? I mean, really obvious, Paul, sorry to pick on you, but I've done in the past, or during COVID mainly, I've done some putting together of food boxes. At that time, that's what was happening, as you know, and we did have, you know, toothbrushes and toothpaste was part of the package, if you like. And so I assume that's still part of the emphasis of your work.
Yeah, we work closely with the NHS when they do the public health, when they do the campaigns around toothbrushes, toothpaste and all the information bags. So we had, I think, 4 pallets of toothbrushes and all the information in our unit. So we do that kind of where we can. Naturally, there's always the resource issue that, you know, our fundamental priority is to make sure nobody goes hungry, but then we're trying to do all the health stuff alongside of that. So it's always a constant, you know, kind of challenge in one sense, but also recognising that, I suppose, what we don't want to do is when resource, you know, is a bit finite, we don't want to automatically put a toothbrush in everybody's bag every time they come, because it becomes a bit, so it's, you know, we kind of manage that, but it is something there alongside other side, as well as our rapidly developing aim to move away from just ambient food that's being given away, you know, alongside that. So it's the double side of that, really.
Yeah, I think it's valuable work, though, the fact that, you know, somebody's really in need, well, they will be really in need at the point when they're engaging with you, that they can access toothpaste. It's quite expensive, particularly the more... I use very specialist, too much sharing, but I use a very specialist toothpaste. It's quite expensive, actually. And also Derby Homes. I don't know if there's anything that I'm drawing on the right person here, I hope, but is there work that you could do here, or do you do things around dentistry or oral health? Or
yeah, I mean, Derby Homes is always willing and happy to engage with partner agencies on many different initiatives. We do a lot of work at the moment with Live Well services around stop smoking, which in turn will have impacts on oral health. So, you know, from a safeguarding and compliance perspective for Derby Homes, I'm always happy to be involved in those discussions and work with service around how we can, you know, strengthen that part of it. We'd always expect housing officers and housing options and homelessness staff to be vigilant around different safeguarding issues, whether that be signs and indicators of abuse, but also oral health. I know you mentioned earlier around young children, being a previous social worker myself, coming across children with oral health issues is something that's quite common, and I think it's important that our staff are aware of those issues and knowing how to respond to that. So yeah, happy to engage with those processes.
I I think you're very well placed, along with the council, of course, to actually be very focused on potential groups that aren't accessing the dentist to tell you off for not brushing your teeth properly. You know, you and us will probably have a good sense of where that is and who it is, and it's something I will raise with the neighbourhood teams, I think, as well. And then, so final comment over here, I think. Thanks.
I suppose the university would be interested to make a contribution to this in terms of looking at small areas to assess the determinants of poor dental outcome, because we acknowledge that there's a shortage of data in to make that assessment of that insight.
That's excellent. Thank you very much. Any other? Sorry, when I said last comment, I didn't mean last comment, I guess. Other people want to come in. I'll bring in Alex first, and then Richard. Thank you.
So just picking up the conversation that we had towards the beginning around fluoridisation and recognising the complexity of the water supply networks, there's a lot of kind of political energy and leadership within Nottingham and Nottinghamshire around the fluoridisation piece. And I don't know, forgive my ignorance, I don't know if that has been joined up on a kind of a councillor to councillor level or kind of health and wellbeing board to health and wellbeing board. But as far as I understand, there is still a kind of live request on some ministerial desk somewhere in Whitehall around fluoridisation. I wonder if this might be an opportune time for Derby and maybe Derbyshire colleagues to, you know, see if that could be refreshed and kind of see if there could be some further impetus around that. So I guess that's partly perhaps a suggestion to you, Councillor Martin, but also to officer colleagues. Might we think about picking that up as we move forward?
It's a really good point. Thanks, Alex. I know, I'll let you come back in a second, Lucy. I know that we have had discussions here around that, and a process was put in place, and you're right, it's gone dormant. So it is something that we could initiate to look at again. To Alan, and do you want to? I thought you've got. I'll let Lucy come in because I know she has views on this. But did you want to? Is there any comeback on that? Do you know where we're at now in Derby and Derbyshire, Alan? Or?
So, as I understand it, we're still in the phase one of local authorities that were initially identified by central government to be further ahead in the process. So that includes Nottingham, who had done a feasibility study already and funded that at some expense to the local authority a few years back, and the North East, which went to public consultation last summer. I've not heard any more from that, but I know the central government's approach was to do it in phases. And then it was for other local authorities who were keen to get involved in that to put a bid forward, but to apply for a public consultation to be supported for that.
Thank you. So we do need to be a bit more proactive about this. And thank you for raising that point. And we have previously. I'm going to let you come in, Lucy, because I know you want to make a point, but. We have previously agreed to support that initiative as a Health and Wellbeing Board. We did actually support that, having had one report where we had grid questions, and we had another report here where we did endorse the initiative, but there needs to be some proactive chasing, I think. Thank you. Councillor Kerr.
One of the issues around this, as I remember from that previous discussion, was that there is a real cost to fluoridation. Not talking about the sort of political freedom of choice situation, which is also a cost politically, but the actual pounds cost of introducing fluoridation. And the cost of introducing and then maintaining fluoridation was very similar to the financial benefit of actually improving the oral health through proactive targeted means. And therefore there wasn't a strong business case for this to be happening. And if the money is available, then we don't need to wait for legislation. We just need to get on with it and improve people's oral health. And therefore, it wasn't. I think this may be one of the reasons why the government haven't rushed forward with it, because it doesn't have that strong business case, and there are other ways of doing it.
Thanks, Councillor Kerr. I mean, I think, so our standing position on this is that we do support the fluoridation, and if that's the correct pronunciation. And so we did discuss your the views that you brought up previously at some length, and we had a second report to address some of those. So our position currently, we can come back to this another time, Councillor Kerr, I think, as I'm sort of running out of time on this particular item. I think our position is that we do support it, and whilst you make a point about the funding, I guess the funding would come from central government for, is that correct, fluoridation? The ICB just won't have the equivalent fund sitting around to focus on oral health. For all that is a good thing, and ideally, Councillor Kerr, we'd want both. But I suggest for now we sit with our current position, which was discussed extensively previously, and if we have any particular concerns, we could perhaps raise that at the next Health and Wellbeing Board. Councillor Hazelgrave.
Just thinking on the whole idea of hearts and minds with the fluoridation debate and those people who are against it, there must have been longitudinal studies of areas where fluoridation has been introduced some years ago and comparing it with a control group where it hasn't, and what the benefits are for oral health and therefore for all the linked issues that arise from poor oral health. If there's that data there, why aren't we making the case in the public arena? Because at the end of the day, as Cabinet Member for Children and Young People, children won't have a voice in this. It'll be voters, yeah? And they're denying children that possibility of that support there every day they drink a glass of water.
Well, what I'd say, Councillor Hazelgrave, and you also make a valid point, along with Councillor Kerr, is that we have, prior to your membership of the Health and Wellbeing Board, we had 2 reports on this, and we discussed it at some length, in a sort of scrutiny-style manner, really, because there were valid points of concern raised by Councillor Kerr, and we had the report come back for a second time to have more assurance about this. So we have seen this kind of analysis previously, but not obviously for a little while. So I think Alex is correct that actually if the position of the Health and Wellbeing Board is that we support this, then we should be proactively pursuing it, I think. And I think that's a valid action point for the Health and Wellbeing Board. Thank you. So I'm going to, we could discuss that at greater length now, but we've had a long discussion on this item, and it is an important part of this item, but it's only one part of it. So I think I'm going to now thank Sarah Busby for her report and Alan Reid for his input on this. Thank you. And we will progress to the next item, which is tackling the effects of drugs and alcohol. A yearly update on the work of the Derby and Derbyshire Drugs and Alcohol Strategic Partnership from Richard Martin. Thank you.
Thank you, Chair. As you pointed out, every year the Drug and Alcohol Partnership, Derby and Derbyshire Drug and Alcohol Partnership, publishes an annual report. This year, as you'll soon see, the report is in the format of a series of small videos linked together describing the successes of the partnership. For those, and I would imagine that's many of you who don't understand or know about the work of the Drug and Alcohol Partnership, basically in 2021 the then government launched a drug strategy from harm to hope. That strategy is a 10-year plan. Part of the requirements of the strategy are that we developed a multi-agency partnership to tackle drug and alcohol harm at a county-wide footprint. Our partnership is called the Derby and Derbyshire Drug and Alcohol Strategic Partnership, and its responsibility is to discharge the national strategy at a local level. The accompanying report, I'm going to speak to one or two points within that report, outlines some of the successes. There are many successes that are being marshalled by the partnership. The videos that you're about to watch don't touch on, or they're not very data heavy. So I thought I'd highlight some of the achievements that have been made as a partnership with regards specifically to the city and more so in general within the supporting information. And they are that over the 4 years of the partnership, so from March 2022 to January this year, there's been over 25% increase in numbers of adults accessing drug and alcohol treatment. So we've got approximately 2,500 people, adults, they are accessing drug and alcohol treatment in the city, which is specifically pretty good compared to the national averages, which are less than that England average. Of note, we focus very much on opiate, crack and alcohol because they are the most detrimental to society. We've got 1,800 opiate and crack users in the city, which is quite impressive in respect of those numbers being in treatment. That's a 61% of the opiate and crack using population in treatment, which is 50% of the England average. So we're doing really quite well with some of the key metrics, and these metrics are reported back to government through a body called the Joint Combating Drugs Unit. Over a period, how do I describe this? Over the lifetime of the Combating Drugs Partnership that we've had locally, there are 4 main strands, and they are to reduce drug and alcohol-related death, increase people's access to treatment, reduce drug supply by smashing county lines and organised crime groups, and to ensure that children do not become problematic drug users of the future by reducing the intergenerational demand for drugs. I have to give praise to the police, who over that period have managed to, and these statistics, you can question me afterwards, these statistics are quite impressive, that in the first year of reporting, there were a considerable number of county lines cracked and smashed. County lines are sophisticated drug networks that either operate within a border or across a border, exploiting young people. So we've disrupted organised crime groups, smashed county lines, and within the first 6 months of this reporting period, 19 county lines have been closed, entering into Derbyshire, and 128 organised crime group disruptions have taken place, and they are drug seizures, drug warrants, arrests, and general seizure of assets. So quite a sophisticated policing operation which persists. The government are very keen for those who go to prison as a result of their drug use or as a result of them using drugs in the commission of their crimes, that they leave prison and access treatment within 3 weeks. Currently 58% of those who leave prison accessing treatment in the city within 3 weeks, which is again higher than the England average and a very good metric because of the link between drugs and crime. And more down to earth, I think, over 1,000 police officers across Derbyshire are trained in the use of a drug called naloxone. It's an antidote to overdose by opioids or heroin. Police now carry naloxone, and at the time of writing this report, 70 instances where naloxone have been issued to people overdosing in public have occurred, and each of those potentially saved a life. So it's safe to say that we, as a public health partnership, a partnership with the police, a partnership with all of the statutory agencies, are working tirelessly to both save lives and reduce drug and alcohol-related crime. Some of the priorities before we watch the video that we've refreshed. We've done some comprehensive needs assessment work and refreshed the strategic priorities, and I propose to list those because there's 24 of them. But as you can imagine, they all revolve around reducing young person substance misuse, reducing death, reducing mortality and morbidity, etc. We've recently commissioned a new treatment system for the city. It starts on the 1st of April for both adults and young people, which is quite exciting. And we've increased the use of naloxone to reverse opioid overdoses and implemented a system of drug tests and arrest. So they are some of the highlights that they've drawn out of the paper. They don't feature too prominently in the videos, but I'm going to ask Lindsay now to maybe click on the link and hopefully it will play. What you're about to see are some key stakeholders, Assistant Chief Constable Shooter, Director of Public Health Robin Jewis, Director of Public Health Ellie Hulston, and the Deputy Police and Crime Commissioner, both speaking about some of the successes we've had and giving like a human context to some of that data. So over to you, Lindsay.
Assistant Chief Constables in Derbyshire Police, and I'm also a strategic member of the Drug, Alcohol and Substance Misuse Partnership, which covers Derby City and the County of Derbyshire. Today I want to give you a clear picture of drug-related crime in Derby and Derbyshire and highlight the work we're doing to reduce harm, increase treatment and protect vulnerable people in our communities. Over the past year, both drug trafficking and drug possession offences have risen in Derbyshire. Trafficking has increased from 738 offences to just over 1,000, which is a rise of 42%. Drug possession has also climbed by 46%, from 1,325 offences to almost 2,000. The current financial year continues that upward trend. I don't see this as a negative picture. These increases reflect better crime recording, stronger scrutiny and improved stop and search training, meaning we are identifying more offences and more accurately capturing the reality on our streets. In 2023 to 2024, Derbyshire saw the highest ever figures for county lines closures and organised crime group disruptions. Although those numbers dipped slightly in the following year, the first 6 months of 25-26 already show strong progress, with 19 county lines closed, 128 OCG disruptions. This puts us on track for another positive year of enforcement. So I guess the bit I want to cover here is, 1, the drugs market is evolving quickly and more dangerous substances, including nitazines, are contributing to overdoses and deaths. To respond to this risk, Derbyshire Police has equipped officers with naloxone. Over 1,000 officers have been trained with an exceptional 98% voluntary uptake. Naloxone has been now used 47 times and in every case has saved a life. So we're also focusing on support as well as enforcement. Operation Trapped is now firmly centred on partnership work and problem solving. Tackling root causes such as substance misuse and drug test on arrest plays a key role in identifying users whose drug use contributes to offending. So far, 953 tests have been completed. More than half have been positive, giving us crucial opportunities to refer people straight into treatment and support. In 2026, our priorities include further developing our naloxone work through a research partnership with the University of Derby. We'll continue to refine drug test on arrest, strengthen consequences for non-engagement and improve our drug testing turnaround times to support investigations. And we'll keep driving evidence-based partnership work to reduce drug-related deaths using data and intelligence to target the root causes of harm. Together, these approaches show a clear commitment, reducing harm, protecting the vulnerable, and ensuring that enforcement, prevention and treatment all work hand in hand. Thanks very much for listening.
The National Drug Strategy, From Harm to Hope, makes it clear that prevention, so stopping drug use before it begins, or delaying the uptake of alcohol and drugs during childhood, will save lives, so it's really important for us to start with tackling those issues with our young people. In the most recent 2 years of data for Derby and Derbyshire, 215 under-18s were hospitalised because of alcohol, a rate that's well above the England and Midland averages. These numbers represent young lives at risk. We know that children's brains are still developing well past the age of 18, and both alcohol and drugs can harm that development. We also know that some children are more vulnerable to using drugs and alcohol, and the earlier people start to use, the more likely they are to have problems as they get older. What can start as an experimentation and fun with friends, or as a way of coping with challenging home lives or anxiety and depression, can quickly lead to problems such as missing school, more severe mental health issues, broken friendships and strained family relationships. Regular drug and alcohol use can sometimes spiral into antisocial and criminal behaviour. In the worst cases, some children find themselves vulnerable to being groomed and exploited, leading to trauma and being trapped in unimaginable and distressing circumstances. In 2025, the Drug and Alcohol Strategic Partnership Board brought local leaders together to tackle these challenges head on. We invited services offering advice, treatment and support specifically for young people in Derbyshire. We wanted to hear from young people too. Through the Here For You initiative, we heard from local students who are creating safe spaces where classmates could openly talk about mental health and stress, helping with problems before they led to substance use. They talked about peer-led work where young people provide support for each other and then access to specialist support services which are vital in reducing harms. We also heard heartbreaking stories, a teenager who used alcohol to numb the pain of bullying and another who experimented with drugs after family trauma. These stories make the data real and remind us why early intervention and care matters. We are committed to supporting those children and young people who need treatment and support services. Working across our partnership in schools and children's services, police and youth justice, we identify the young people who are really struggling with either their own alcohol and drug use or that of a family member and offer them support to provide hope and a better future. We also know that early intervention can make a real difference. Our next steps include increasing school-based programmes so that every young person learns facts about drugs and alcohol and the consequences, along with the skills for them to make the right decisions. We also use the data to target support in more disadvantaged communities, where we know children are 1.5 to 2 times more likely to end up in hospital from alcohol and drug use. We are keen to continue listening to the voices of young people, recognising the value of their experiences and that they are the experts in their own lives. By focusing on preventing drug and alcohol use before it starts, we can reduce the number of young people needing specialist support and change futures for the better. Prevention today means hope for tomorrow.
My name is Dr. Fatima Altanay. I'm the Deputy Police Crime Commissioner for Derbyshire. The Listening to You survey continues to give the partnership a strong evidence-based understanding of residents' experiences across Derbyshire. In 2024 and 2025, 3,675 people took part. That represents 1 in every 290 residents. The respondent group was broadly reflective of the county by gender, age, geography, ethnicity, and sexual orientation. The results show that drug and alcohol remain persistent issues across our communities. 20% of respondents said they experienced street drinking or drunken behavior on a weekly basis. 22% told us they witnessed drug use or drug dealing weekly. The highest levels of street drinking were reported in Narrowash, and the highest levels of drug use and dealing were reported in Derby North, including the city centre. These findings will be refreshed after the survey closes on the 31st of March 2026, helping us to track changes over time and measure the impact of DASP activity. The public assurance meeting process has strengthened transparency and accountability around drug and alcohol-related work. From the 17th of February to the 3rd of March 2025, the Office of the Police and Crime Commissioner invited public questions on this thematic area and received 30 questions in total. Any case-specific details were removed and dealt with through casework. The remaining questions were passed directly to the force for formal response. These covered enforcement, reporting, and community engagement, and all responses were published on the Police and Crime Commissioner's website. The Year 2 public assurance meeting for this priority has opened on the 26th of January and will run until the 4th of February, giving residents another clear opportunity to scrutinise progress and raise their concerns. There have already been over 40 questions so far for the 2026 public questions on drug dealing and substance misuse. A dedicated victims of drug and alcohol-related crime survey has been co-developed by the Office of the Police and Crime Commissioner, Derbyshire Victim Services and partners to capture genuine lived experience directly from victims. The survey launched in January 2026 and will be running till the end of February 2026, with full analysis to be shared with the DASP at the end of March 2026 to inform our priorities for 2026 and 2027. There have been over 400 responses so far. Lived experience is also shaping service delivery. As part of our partnership approach, we jointly commissioned drug and alcohol services, including the 1625 outreach service. This ensures young adults affected by substance misuse receive specialist and age-appropriate support. This joint commissioning approach strengthens early intervention, victim support, and pathways into treatment, all guided by what victims and communities tell us through engagement and survey insight.
When we look at drug and alcohol related harm across Derby and Derbyshire, the scale and complexity of the challenge is clear. Across the partnership area, it's estimated there are 4,800 people using heroin or crack cocaine, 2,988 in the county and 1,812 in the city. Encouragingly, 60% of drug users across city and county are in treatment, well above the England average of 46%, showing that local investment and engagement do make a difference. Alcohol, however, presents a much bigger treatment gap. Around 11,821 people are estimated to be alcohol dependent, 8,654 in the county and 3,167 in the city, yet only 25% of dependent drinkers in the county and 35% in the city are currently receiving treatment. This is, however, comparable to the rest of England, where treatment uptake averages are 24.5%. The consequences of drug and alcohol misuse are severe. In 2024, 95 people died from drug misuse across Derby and Derbyshire. Chesterfield has the highest rate of drug-related deaths in the county and the second highest rate in England per 100,000 people. Alcohol causes even greater harm, with an average of 208 local alcohol-specific deaths every year, a rate of 20 per 100,000, compared with an England average of 15 per 100,000. Over the last 4 years, partnership spending on treatment has increased by more than 30%, and we now invest over £10 million each year in treatment, prevention and recovery support. There are currently nearly 7,000 people in treatment across our area, 4,429 in the county and 2,548 in the city. We're also improving continuity of care. 57% of people leaving prison with a treatment need are now accessing drug and alcohol services within 3 weeks of release. With regard to quality of treatment, importantly, 41.6% of people in treatment are making substantial progress, either completing treatment or significantly reducing their substance use. This is comparable to the England average of 46%. This work is paying off. Hospital admissions for drug poisoning have fallen by 22%, from 425 admissions in 2022-23 to 330 in 24-25, bringing us below the England average. Looking ahead, there are emerging concerns. Powerful man-made opioids, known as nitazines, now circulating, are significantly stronger than heroin and far more dangerous. Similarly, veterinary tranquilizers are also being sold and equally pose a serious and growing risk. In response, we've strengthened joint plans with emergency services, expanded access to the overdose antidote naloxone, and developed a local drug information system that monitors drug threats daily. At the same time, alcohol harm is increasing. In 2023-24, there were 6,955 hospital admissions where alcohol was the main cause. Derby has the highest rate in the region and Derbyshire the third highest, both well above the England average. These figures underline why sustained investment in treatment, prevention and recovery is essential, because it saves lives and protects our communities.
And I think that's it from me, Chair.
Well, that's really excellent. Thank you, Richard. That's a really excellent overview, and I have some comments, and I'm sure there'll be some questions. I mean, it does look like a relatively quite a positive picture in the moment in terms of treatment, particularly in relation to drugs. On the other hand, I'm sure I saw my fellow councillors' faces, and certainly my own, is that it's quite shocking to know the extent of the problem, even though we've been told it before. And still, the numbers seem quite shocking to me. The room will have to forgive me for a minute before I take sorry, Richard. Before I take questions on Richard's excellent presentation, forgive me. I have to go back to the oral health strategy report because I got so carried away in talking about the fluoridation project. I forgot to ask us to confirm, quite importantly, recommendation which no doubt you had noticed, Sarah, 2.3, which is asking us to confirm the governance and oversight role of the Health and Wellbeing Board for the Derby and Derbyshire Oral Health Strategy. Does the Health and Wellbeing Board, are you happy to accept that recommendation? Yes, thank you. So apologies for that. Right. Okay, so back to the report in hand. So thanks again, Richard, for something really excellent. It's nice to see those people who are so actively involved in the partnership, aren't we? And when I can come along, we see them, we discuss, and it's nice for them to be showing the Health and Wellbeing Board how much engagement they have and the work they do. Any comments or questions for Richard, please? Councillor Kerr.
Thank you. And this is an area which I feel is so wrapped up in sadness, I think, really, because people who are dependent or semi-dependent on drugs and alcohol are often fighting something themselves, and they're not in themselves happy with that situation. And the people around them are also unhappy with that situation. And what we can do to improve it, I think, is, it would be good in so many different ways. And I'm just wondering whether the partnership that's looking into this, how closely it's engaged with the licensing side of things, which is providing the access to the alcohol, which seems to be the most unaddressed problem here, in that the police are so much more proactive about the harder drugs. And that relationship needs to be not just obviously with Derby as a licensing authority, but while they continue with those roles, the county, boroughs and districts who have their roles locally. And I'm just wondering how closely that work is going on and whether there's more that we could be doing in that area.
That's a fantastic question. Obviously, what was presented today is a whole county picture, and specifically the headlines. Beneath the subcontext is that we did a huge piece of work across the last year, culminating in November, where we set out 24 strategic objectives. One of those, a mere headline, is to reduce the harms caused by alcohol, and many subsets of that are to develop sophisticated profiles about alcohol consumption, alcohol use and alcohol harm, develop an alcohol harm licensing matrix which will allow us to analyse specific areas for the density of licensed premises, on-off and licensed premises and supply of alcohol, and juxtapose that with crime and hospital admissions and employment and low attainment. So I think it's fair to say that the work of the DASP is very aligned largely to reducing alcohol-related harm. Those works take place at a local level, and locally, I think we've just finalised the alcohol harm matrix, and I'm more than happy to come here, if invited, to present the alcohol harm matrix, which is very, very sophisticated. You'll be very happy with it. In the sense that it deals with maybe 10 or 15, maybe 20 metrics, and you could drill down in layers and point out at a postcode level where there is a high density of alcohol premises, where there shouldn't be a high density of alcohol premises, where they coincide with areas of deprivation. I can't say that we can alter licensing decisions, But in other areas, that licensing matrix approach has been valuable in objecting to the granting of licenses. So we're on it. You and I have spoken outside of this meeting, and I absolutely agree that Derby has too high a density. I think it has something like 719 licensed premises in a 28 square mile of the city. We don't need that many in relation to supply and demand and need. There isn't, or there wasn't, the evidence that demonstrated we didn't need that many. I'm confident the licensing matrix will give that evidence.
Thank you, Chair. I'd really welcome to be able to the board to hear that more in-depth information about the result of that research, and if we can squeeze it into our work programme as soon as it's available, I think that would be great. I am just in terms of this link between public health and the role of licensing and policy within the licensing field. I think there may be an area there that we could explore easily within the city, but maybe the county could explore with the other licensing authorities, so that they are fully aware of that they have a role in improving public health locally by setting the right sorts of policies and then implementing them.
Yeah, if I could come back on that. A colleague of mine who is actively involved in licensing decisions for public health in the county is very, very proactive, and they've got a slightly different arrangement in the fact that they review all licensing applications, and not only do they review them, but they also seem to have a say in the granting of licenses and the extension of licenses and licensing hours, something that we maybe have been denied as a responsible authority in the city. So we're looking to redress that. I've slightly greater confidence, they're much higher volume, I have slightly greater confidence that public health in the county are more proactive in relation to licensing decisions. Specifically, yeah, I've seen a colleague operate in that steer, but we need to harmonise, don't we, if we look at RGA.
I'm interested not only in the decisions about that particular application and its appropriateness, I'm interested in the policy behind this, because the policy will set the nature. I was talking to a publican in a Derby pub licensee, and he was commenting that if he is selling alcohol, he or one of his trained team has to be there to be in the premises to be able to be doing the selling. The person behind the bar themselves may not have to have the full qualifications, but there has to be somebody in the building and they have to be responsible. If somebody is delivering alcohol to somebody's doorstep, the person who's doing the delivery has no qualifications at all. It's an Uber driver.
So what I'm going to say, sorry, Councillor Kerr, I'm going to interrupt here because I'm very mindful of time. This is a very important point, but no one else has had a chance to come in on this item yet. I'm actually with you on this, so don't worry, I'm not dismissing it, but we are behind time now, and this kind of detail is something we can pick up again when Richard brings his further report. I am going to close you down, Councillor Kerr, sorry. You've had 3 stabs at the cherry there, and the point is accepted. We aren't going to discuss that in huge detail today because it would relate to a further point, but it is something that I share exactly what you're getting at, exactly your concerns, and we're not going to pursue that in detail today. Thank you, because we've got the whole report to consider, and I need to know if anybody else wants to come in. I've got the next report, but thank you. It's a very important contribution. Thank you. Councillor Hazelgrave, thank you.
I'm just going to state the obvious, but the NHS is a national organisation right across the UK. I'm just thinking of 2 points about the learning here. There has been some learning by this kind of wraparound approach, and it has had really good statistics, positive statistics. Are we sharing that with other ICBs or health, whatever the equivalent is? And the other thing, in Scotland, for alcohol, they have certain rules, and I think the pricing is directly related to the unit of alcohol and all sorts of rules about you can't reduce prices, etc. Has that, which has been around for a fair time now, has that had an effect on actual alcohol consumption? And could that be a lesson for England and Wales as well in terms of that?
I think the jury's still out in relation to unit pricing and whether it has a longitudinal impact. Logic would dictate it would, because we have almost priced out the affordability of tobacco. The danger is that then you open up black markets and substandard qualities. I think we see a run a risk of, if unit pricing goes so high, that unscrupulous types will start to use methanol in the supply chain and will sell these obnoxious liquids. I think from a public health perspective, unit pricing is a good approach, but as I say, reaches a plateau. I think some years ago, I came to, when the government was floating the concept of unit pricing, and we were able to have local discussion, local consultations, I came to the licensing committee, and it was kind of seen as a bit of a public health, big brother, don't tell me how many wines I can buy. I didn't come back again after that point. As for the shared lessons learned, I think, yes, Derby and Derbyshire are an outlier in relation to alcohol-related harm, but some of the initiatives and the pathways that we've got, like the alcohol care team, speaking to my colleague's point, that in their the 5-year and 10-year plan and the commissioning strategy, there's strong reference to reducing alcohol-related harm and improving pathways and relationships between hospital and the community. I think we just need to allow what we've started from the graphs and charts to embed, and we will see some positive outcomes, because we are like a massive tanker in the fact that it takes on average 26 years for you to start drinking and have a long drinking career before your liver feels the damage. Your liver arguably has no nerves, so by the time you're feeling liver damage, you arguably have 6 months of life left if you don't stop drinking. So it's very difficult to turn that tanker, but we're doing all we can, and we have to start with young people, children and young people.
Thank you, Richard. Right, one quick last comment then, please, Paul, because we do have one extra important item that is kind of going to feel squeezed, I know, and we've got somebody here from Derbyshire to talk to us about that. So your last comment, thanks, Paul.
Yeah, two little quick things. One, thinking in terms of the Poverty Commission, I think it'd be interesting to kind of think in terms of the impact in terms of, people in deprived communities and, the increase in terms of, I'm assuming here, increase in terms of, use of alcohol and drugs within those. It might be something that we need to think about how we make sure that that's in the action plan for the work of the Poverty Commission to link in. And then secondly, in terms of kind of, the day job of the food or furniture or that side of it, it might be worth having a further discussion about, because naturally we don't ask when we're asking why people are coming through, do you have an, addictive, behaviour? We obviously don't ask that, but naturally lots of people coming through do have that, and it might be worth thinking what we can do more as an organisation to kind of, help as part of this as well.
Yeah, the more the merrier, I think, and the greater the degrees of integration of the treatment system. I was going to raise a point to what Dr. Busby had said, in the sense that the drug and alcohol treatment system and the Public Health Commission Services 0 to 19 public health nursing are hugely aligned to your oral health strategy. Often dependent alcohol users and drug users are overlooked in relation to their dental pain and their access to treatment, specifically the homeless. So I know that we are in those types of conversation, but it would be good to maybe strengthen those conversations so that we're more present. And similarly, with regards to Poverty Commission and the work of poverty and whether people would eat or drink, we need to be definitely getting ahead of the curve with early intervention and prevention. So, yes.
Okay, thank you, Richard. Sorry to close that down slightly there, but that is a really excellent report. We're being asked to note it, and I'm sure we have. There's been a lot of engagement. I think there would be more. And I think it is good because a while ago you were concerned about take-up. There was an issue with take-up of services, wasn't there? And our understanding is that we are reasonably well, this is an area where we are reasonably well funded, so that's really novel for anybody in local authorities. So yes, we've got some money, and it's now good to see that people are taking it up. And I think we've had a really good discussion from members of the board about the broader issues that could be causing some of these problems in the first place. And Councillor Kerr raises a very good point, and I think that we would like to have you back fairly soon, please, with another report. And thank you very much for that. Thank you. So now, with just half an hour left to go, I'm going to move on to our final report, which is self-harm and suicide prevention in Derby and Derbyshire. In Derby, actually, and the Derby and Derbyshire self-harm and suicide prevention strategic framework 2026 to 30. And we've got, I know you're involved in this, aren't you, Alan, as well, but James Crehan from Derbyshire, who does a grand job, because I've dealt with James before. He's going to present the report for us. Thank you, James.
Thank you, Chair. So yes, James and I are here today to take the board through the Derby and Derbyshire self-harm and suicide prevention strategic framework for 26 to 2030. I just want to start by recognising, of course, that this is a sensitive and emotive subject. Many people in the room and people watching on the broadcast may have been affected both professionally and personally from suicide, self-harm or suicidal distress, either themselves or people they know. So please do take time to look after yourself during this discussion. If anything feels difficult, it's absolutely fine to take a moment, step out if you need to, or seek support afterwards through your usual support, local services or organisations such as the Samaritans, which can be contacted on 116 123. Our purpose here today to this approach is to treat this with compassion, but also with hope. The message is that suicide is really not an inevitable part of life. This is a shared city and county framework, but we also want to be really clear about what this means for Derby City and how the board will help keep this visible and practical locally. Next slide, please. So for Derby, the numbers are relatively small in statistical terms, which means we need to be careful about over-interpreting any year-on-year changes, but actually what we know from a human impact, these numbers aren't small at all. In the latest 3-year period from 2022 to 2024, there were 83 Derby City residents who died by suicide, and that's an average of 28 deaths per year. 2/3 of those deaths were among men, and behind each number, of course, is a person, a family, a workplace, a community, a friendship group. The figures on the slide show that up to 135 people may be affected by each death, and that's really a helpful reminder, we think, that the impact reaches far beyond the individual. For the Health and Wellbeing Board, I think that underlines the important opportunity to keep suicide prevention visible, connected to our wider inequalities work, and practical enough so that partners can see what they can practically do. Next slide, please. So this slide gives us some of the more Derby-specific data in a bit more detail. As I said, the suicide rate for 2022 to 2024 is actually above the national and regional rates, and men, as we know, remain the largest group affected locally. The 5-year data shows that males aged 25 to 44 are particularly prominent in Derby in those figures. We've also added 2 wider national survey findings here, because I think it helps to change how we might look about suicide prevention. And what we see from that is around 1/4 of adults report having had suicidal thoughts in their lifetime, and around 1 in 13 adults report having made a suicide attempt. And I think that tells us that suicide, distress and self-harm are much more common than suicide deaths alone. Also, between 2/3 and 3/4 of people who die by suicide are actually not in contact with any mental health services. So prevention, that means that prevention can't sit alone within specialist services. It's necessary to include prevention in primary care, workplaces, within communities, families, schools, the voluntary sector, faith partners, and really everyday settings across the city. Next slide, please. A really important point in this framework is that self-harm and suicide are often expressions of distress. They're not in and of themselves a mental illness or indicative of that. Of course, mental health is an important picture for some people, but the wider factors in this slide matter hugely. It's all financial difficulty, isolation, experience of domestic abuse, trauma, substance abuse, as Richard's been talking about in the previous item, gambling harm, even physical illness and caring responsibilities. These are all areas where the Health and Wellbeing Board partners have major influence in. In Derby, that connects strongly with urban deprivation and inequalities, cost of living pressures, our younger and diverse population, students, workers, and people who may not actually seek any formal help. And we see in the statistics in the previous slide, that's actually a lot in relation to suicide. Men's mental health is a key issue here, given the disproportionate representation of men in suicide figures. We need to reach men in places where they already are, so workplaces, pubs, clubs, sports, obviously also in primary care and community spaces. And we need to use language that reduces stigma and makes those conversations easier. I'm now going to hand over to James to take us through the detail of the framework itself and the work of the partnership's been doing. So thanks, James.
Thank you, and thanks for inviting me today. So I'll touch on the framework and just to really emphasise that it is a partnership framework. So there's been a lot of work that's gone into this, from revising and refreshing the previous framework that we had, taking into account the National Suicide Prevention Strategy that was from 2 years ago, and yeah, representative. So we have a multi-agency partnership that's existed in Derbyshire for about the last 15 years, with the long title there, the Derby and Derbyshire Self-Harm and Suicide Prevention Partnership Forum. So I've chaired that for the last dozen years or so, and it's really, really well represented by local organisations, both statutory organisations and NHS services in particular, but also predominantly by VCFSE organisations. So, for example, Derby Samaritans have a really strong voice on there and contribute to the development of this framework and the action plan that comes out of it as well. And the idea of that is to pull together opportunities for best practice, information sharing, connectivity between services. As Alan has highlighted, prevention is right in our communities. It's not linked to health services. So we have to engage with the partners who have contact with people in our communities. That's where it really, really starts. So ultimately, I'll talk you through some of the framework, but we want the board's endorsement to make it feel owned by Derby City. Although I lead the partnership from a county perspective, there is strong city representation on there. Next one, please. So we've had a vision in place for a few years, which was co-produced by that range of partners and particularly by people with lived experience. And it's really trying to emphasise the positivity side of it. So if we can give people the protective factors and the support mechanisms to prevent them having mental ill health or suicidal ideation in the first place, but there is a recognition in there that people do struggle with distress and despair. And that's a longer spectrum. And we know that at any point along that spectrum, people could have self-harm or suicidal ideation. So it's not to the acute end at all. It is at any time and any place. There are a few principles that we try to work to, and these are evidence-based. One is that suicide is not inevitable. In the inquest reports and the evidence that's been collected nationally and locally, there are always opportunities for a different change of direction during the journey of an individual who ultimately takes their own life. So it's not accounting any blame anywhere, but it's actually saying if we're more acutely aware of the opportunities at different stages, we can make a real difference to that outcome. Everyone has a role. It's around conversations and reducing stigma so that those conversations can be compassionate and non-judgmental. It's understanding people's journey, people's story. We hear a lot through services about people being frustrated about telling their story again, about not having consistency within support workers that they see. So how can we change that? It's around safety, and it's around the impact. So Alan touched on the 135 people who were affected by each death by suicide. That ripple effect can have a real impact on local communities. And when you look at different settings like workplaces, schools, sports clubs and other things, that's where that ripple can really have an inadvertently negative impact. We know that people who've been affected directly by suicide are at higher risk of suicide themselves. So we have to take that into consideration with regards to prevention. Next slide. Okay, so in the new strategy, we've got 8 priorities, and these align very well with the National Suicide Prevention Strategy, but also reflect what we have gathered from a local level as well. So number 1 is basically what it says on the tin: make it everyone's business. Every single person can play a role in suicide prevention. I'm going to touch on 2 and 3 in a couple of slides' time, which is around the high-risk groups and the factors. In reducing access to methods and means, number 4, there are a couple of components to this. One is around how can we consider designing in suicide prevention mechanisms when things are being developed. So if you think of structures, think of bridges, multi-storey car parks, new hospital wards and places like that, are we weaving in suicide prevention in the design of those places? The other part of that is us really understanding the suicide trends that we're seeing, both locally, regionally and nationally. So, for example, there might be a novel method. There might be a different substance that's being used. So what Richard has touched upon and the insight gathered around the use of substances is really important for suicide prevention as well. Number 5 is around, if you just go back, sorry, Lizzie. Number 5 is around online safety and responsible media content. We know there's a load of work going on at a legislation level right now around reducing access to social media for young people, which hopefully will restrict some of the dangers they encounter online. Another part is responsible reporting. So our local media, our local communications teams, there is some brilliant guidance produced by the Samaritans which clearly states what should and shouldn't be done in reporting, such as images of a location should not be shown, explicit descriptions of methods should not be shared. The other part of it is whenever there's something occurs within a public place, it's on social media instantly. So, and again, inadvertently, people can share things that are damaging or harmful to other people. So again, can we appeal to our local Facebook groups and others and equip them with the skills to respond to things responsibly? Suicide bereavement support is number 6. We've got 2 great local providers who offer that support at the moment. The first is a Tomorrow Project, who offer kind of clinical support, counselling support to anyone affected by a death by suicide. That includes children and young people, and they also offer support into settings that have been affected by a death, such as a school. We've also got Survivors of Bereavement by Suicide, who offer peer support for adults. They're led by facilitators who have been bereaved themselves, and they offer that kind of support circle where people don't feel alone and they can share their experiences with the differing emotions that a death by suicide can bring. Research, data collection and monitoring. The evidence base nationally and internationally is improving and increasing, but it's still massive deficits in it. So, for example, we're still not getting it right for men. So we need to learn more. We need to develop more evidence-based initiatives to counteract the high rate of suicides amongst males. The other side of it is the data that we get. So we get official data from the Office for National Statistics. That's data which has gone through a coroner's inquest where there's been confirmation that suicide was the cause of death. The trouble with that data is the lag time. So from the date of death to date of inquest, it can be around a year. And then the date when that data is released can be another year. So we're a couple of years out of date sometimes with that data. Great for longitudinal trends, but we need to know what's happening in real time. So we have a secondary system called real-time suspected suicide surveillance, where we receive information from Derbyshire Police and from British Transport Police on deaths by suspected suicide. What we're able to do then is identify if there are any clusters occurring. So that could be a demographic of our population, such as teenage girls. It could be a specific location where we're able to then stand up a cluster response and go and mitigate and prevent any further incidents happening in the immediate future. The final priority there is around crisis support. And the key message within this is that support and prevention begins way before the point of crisis, way before the blue light response. It begins by giving people the opportunity to have a safety plan, to have support networks, and to have protective factors in place. And again, that cross-cuts all of the wider determinants of health that I think we've heard throughout all the presentations so far. So I'm just going to talk about the priority groups and the factors. And a couple of things I want to highlight before I get into it is These are all evidence-based, so these are reflected in the national strategy. They are the ones with the strongest evidence base to say these groups of people and these factors are the highest that may lead to self-harm and suicide. The second point I want to highlight is around language and the importance of language. So what we've tried to do through this local framework is change language in order to reduce stigma, which in turn will help people to open up, to disclose, and give people confidence to ask questions around it. So if you see the top right column there, national, the factors that may reduce safety, ordinarily that's called risk factors. And again, what do we think of when we think of risk? We think of red flags, we think of fear, and actually that's stigma in itself. So we've tried to change the language to make it more inclusive. Another language change is around neurodivergent people. So in the national strategy, that's autistic people. So again, we recognise the range of neurodiversity and conditions that may affect people, so want to be more inclusive in how we approach self-harm and suicide prevention locally. We did ahead of the framework last year, we did a lot of engagement and outreach work. We got a lot of insight from local groups and partners, and the bottom columns there are what have emerged that local people want us to also focus upon. So we've got a really large deaf, blind and hard of hearing population. Of course, we've got the Royal School here for the deaf in Derby, and they had a really strong voice about saying, look, we really feel our community is affected by this. So we're doing some great co-production work with them at the moment. There was a British Sign Language Day just last week in the Market Hall in Derby, which we were able to engage and provide some resources to people around self-harm and suicide. If you move on, please. So last year, hopefully you saw this. This was part of a national tour of the Baton of Hope, the second national tour. We hosted a leg here in Derby on the 13th of September, which was a Saturday. If you move on, Lindsay, please. And what it enabled was the raising awareness was the biggest thing, really. So over the course of the day, there were over 80 baton bearers from the local area who carried the baton for a leg. So it's like an Olympic torch where they carry it for a leg and hand it on to someone else who has been affected by suicide themselves. There were various stop points along the way. It began at Elveston Castle, just over the border in the county, but made its way to Darley Abbey and ended up at Cathedral Green for a celebration event at the end where there was music and a lot of stalls. So it was brilliant for awareness raising. The number of people who attended various points along that route and contributed, raised awareness, but it's a point of raising awareness and can we build legacy from it. So we've done some localised actions from it, but again, it's something we can build upon for the future as well. If you move on, please. So the strategy is one thing, making it real and actionable is another thing. So there were two simple actions that we came up with as a partnership and through the engagement that we wanted to focus upon. The first is ask, listen and act. And what sits behind this is giving everyone, and literally everyone, the skills to be able to ask a question in a compassionate and non-judgmental way. So how do we do that? How do we give people that confidence and that skills? We heard a lot that people won't ask the question because they don't know what to do with what the response may be. They're scared of asking it because they're scared of handling the response. So we want to equip them with the skills to do that. The second part of that is about active listening. So listening is hard at times. It's hard not to interject. It's hard not to give solutions. So how do we give people the skills to listen actively? And then know what to do with whatever the conversation occurred from. So it could be as simple as, we'll have a cup of tea, let's go for a walk, here's some information about a local service, or it could be a 999 call if there's life at risk. The second part of it is around the use of safety plans. And these have been seen historically as something owned by clinical or social services that only a clinician and someone properly trained can do. And that's not the case. Anyone can initiate, own, and develop a safety plan. So the more people we can support to introduce these with others, to develop their own, the safer they can be. And a safety plan is basically, when someone's well, outlining what are the things that cause me distress and how can I identify when I'm starting to feel that way. What are the things that make me feel better, that can divert my attention away from that escalation towards distress? So listening to music, going for a walk, ringing someone up, something as simple as that. And then what's the support network that I will need around me? And to have that safety plan in place before a moment of distress can really help when that distress occurs. And what we've tried to do with the call to action is develop an approach for individuals. So how can we appeal to members of the public? How can we appeal to individuals in organisations and make it easy for them to uptake these things? We're setting and framing some actions for communities, organisations and businesses to be able to take forward. So from small groups of a couple of people up to our huge businesses, they can make a pledge, they can train their staff, they can adopt processes that really embed self-harm and suicide prevention. And then the third component is around the system. It's the big brother side of it. So the partnerships such as this one, the boards, the decision makers, the commissioners, how can we weave it into contracts? We touched upon licensing and alcohol licensing. Actually, how can we weave in something around suicide awareness into the licensing for alcohol, for taxi drivers and things like that through the statutory processes that we have? So there are opportunities that we can make this business as usual rather than being an add-on and rather than being something that someone is a bit scared of addressing. Can you move on, please? Alan.
Thank you very much, James, for that really detailed overview, very helpful. And I'm just going to pick back up from the Derby City perspective, and I think the main point I want to make here is that you've seen it's a city and county shared piece of work, and I'm really grateful in terms of, from my own personal perspective, of working with someone so expertly as James, who's been in this field for such a long time. City and county, just like in the oral health strategy, works so well together. Obviously, that's relevant for LGR and the discussions there, and I'll touch that in the on. But it's really important, despite the fact it's a city and county perspective, to get that Derby City focus into this. And already there's a lot happening in the city, but as ever, we need to make it a bit more visible and easier for partners to connect with, as you've touched on, James. And as you said, the Baton of Hope visit to Derby last September was a really very positive, as you say, and powerful, visible example of the city stepping forward on suicide prevention, raising awareness and creating that positive energy around collective action. We'll also have the city public health leadership team linking into the Health and Wellbeing Board into place in neighbourhoods, with my own hat on as the chair of Derby Place-Based Partnership, linking into the DHIP work, the Derby Health Inequalities Partnership. So in practical terms, Derby City Council offers a lot of routes where this could be taken. We've got the offer of mental health first training to local people and workers. There's community-led important projects such as the Mentel peer support group for men, as we've seen, so necessary. Alongside that, we've got partners who are promoting crisis support, safety planning and training, resources, plus that postvention and bereavement support for people affected by suicide. I think the next step for us is to make this, as you say, James, make it feel more accessible and actionable for services, workplaces and communities. Just next slide. So what we're asking the Health and Wellbeing Board to do here is deliberately practical and intentional. We're asking all members of the board to endorse the framework as that shared strategic direction for Derby and Derbyshire, and also to make suicide prevention everyone's business in Derby. That's the key message. Doesn't mean every organisation has to do everything. But it means every partner can identify something meaningful and visible that they can do, and that might be training staff, promoting support routes, embedding safety planning, strengthening postvention arrangements, and thinking about staff health and well-being, or connecting suicide prevention into existing work on safeguarding, poverty, housing, substance misuse, as you've said, James, gambling harm, domestic abuse, community safety and neighbourhoods. Also asking the board to keep the inequalities lens on this, particularly around men's mental health and other groups and factors that James has described when he went over the framework in detail. That board endorsement helps really to signal that this is not a niche mental health issue, it's core health and wellbeing board business. Last slide for that. So finally, in terms of next steps, I think the framework gives us a strong platform through to delivery to 2030 of the framework. The call to action will be developed in stages with practical tools, training, safety plan resources and communication that partners can use locally. I think for Derby, I want to keep the city data and the city activity visible in that partnership reporting to make it real and to show the impact and to build on that Baton of Hope legacy that continues beyond a single event or campaign. As I said, we need to be clear on what local government reform will mean for our joint working. This work has always been approached through a Derby and Derbyshire footprint and really would expect that whole system approach to continue in any future arrangements. I think the key will be retaining clear governance and leadership, those data flows and that cluster response and post-vention pathways, and making sure that Derby City communities and inequalities remain clearly represented. I think to sum up, a shared footprint gives us that continuity, but a clear Derby focus gives us that local accountability. Thank you very much.
Thanks both. I mean, it's a really great and comprehensive report and clearly focusing on an issue that's sensitive to many of us. And Alan, could you turn your mic off, please? So I am going to just raise a critical and technical point, though, before I bring everybody else in. What really concerns me about this report is the erasure of women in it. We know the focus that men are the ones who actually succeed in the act of taking it through, but my understanding is that more women tend to attempt to take their own lives more and aren't successful, so the mental health of women. I also personally would object to the referencing of men as a gender as men and the erasure of women around referring to people in the perinatal period. I presume you mean mainly women. I think that's quite important if we're going to get... I know there are some people who have give birth to children and they think they identify as men, but there are also people with penises who identify as women, and we are happy to use the word men, but we will not use the word women. There isn't a reference to women in the entire report. So I personally have concerns about that, notwithstanding, as Alan very well knows, my own and many others' deeply held concern for the young men who take their own lives. So it's not a language we particularly use here in Derby City, that kind of use of person rather than women. So I would object to that in that report. But putting that to one side, do we have any other comments, please? Paul?
Yeah, two things. One, I've been saying for a long time about, voluntary and charities and faith sector probably engage with more people with lower level mental health than any other sector in the city. Yet we, as a city, don't really have a strategy how to best upskill volunteers in the city. And I've raised it a few times at this meeting, and I still think if you look at priority 1 and 8, that's a massive thing that I think needs to be something that I'll keep going on about till as a city we do something about. I think the second point is around, Richard will remember many moons ago, he had an international speaker here around trauma-informed work and that, and it's really valuable. But if I look at it, again, as a charity, I don't know if we deliver our work in the best trauma-informed way, because I guess accessing training without having to pay a fortune as a charity, it's very hard to do. So again, I think it's something really important that specifically about the best, because you can learn what trauma is, but we need to know what do we do next? And I think that's something, again, across the sector, certainly, that I think is something important that would be great to look at. Thank you.
Yeah, completely acknowledge that. I mean, I would really hope that the work we do with the Derby Health and Equalities Partnership and working with Community Action Derby would help to address that connections with the voluntary sector and the upskilling of that. We've got the Mental Health Collaborative, so there's lots of routes for that, and I think definitely through our partnership working here at the Health and Wellbeing Board and through the Place Partnership Board, where the voluntary sector is heavily represented there, try and get those messages out. Regarding the trauma-informed training, I think absolutely we all recognise that. Again, Derby Health and Equalities Partnership has been championing that cultural competency training, so why? I'm sure that trauma-informed care and training could be something they could look at as well.
Thank you. Councillor Ashby.
Thank you, Chair. Thank you very much, both of you, for a really comprehensive report with a huge amount of detail. I would like a couple of things, please, going forward. I would like you to come back in the next year or two to, you know, we'd like some, I think the stats that we saw were primarily 22, 24. So hopefully we're going to, you know, you're doing a ton of work. So we would like to know in the next year or two whether it's bearing fruit. And I would also like to second what Paul's just said. You've said, yes, we'll take it away. What we would really like is for you to come back with a plan to make trauma-informed work and training for that accessible to charities like Paul's, but also not just the trauma-informed, but how to ask those questions. You know, I've come from healthcare. It's really hard, even as a healthcare professional, you have to learn to say to somebody, have you thought of hurting yourself? Do you think, you know, do you wish you weren't here? Whatever, however you do it, but you have to learn to do it. It feels like a huge thing to ask somebody unless somebody's gone through that with you. So I'd like you to come back and tell us what you're going to do to spread the range of those people who can actually help prevent suicides. And I absolutely agree with Councillor Martin with regards to, we want women called women in this report. The people who nearly die around, you know, the risk around perinatal period. We know the stats from 0 to 2 years postnatal are the women who've had the children who've had postnatal depression, etc., etc. So, yeah, but thank you. Great report.
Thanks, Councillor Ashby. So I've got, we are, look, this is, I take full responsibility for this. We are out of time, but I'll take some questions if people are happy to stay. I know some people will be on parking meters and things or whatever and need to go, but I'm happy to have a few more questions if people are happy with that. It's a really important report, we know. So I think I got Councillor Hesselgrave first, then I think I got Councillor Kerr, and then Richard. Thank you.
Very quickly, thanks to Alan and James for being such powerful advocates for this and presented it so clearly. I learnt a lot and some quite shocking things to learn as well, and family history as well. But I think this issue of local in Derby, including the deaf and hard of hearing community, is really, really good because, as we all know, I hope, that it's the second largest community as a proportion of the population outside London. I'm assuming that the hard of hearing are kind of people who are getting older and then become isolated and frustrated, or is it just something that is all across all ages? And also, I really want to support what Paul said, and also what Alison said about women maybe not arriving at suicide and completing it, but the whole process of having the ideation in the first place. Thanks.
Yeah, thank you. I'll try and speak and turn at the same time. The hard of hearing part is both ends of the spectrum, really. Technologies are getting much better about supporting people who have an element of deafness, whatever age they may be. But there is the element about people as they age losing their hearing as well, and therefore losing a bit of independence and becoming more isolated. So there is actually a Derbyshire Deaf Mental Health Forum, which I sit on, and is led by the deaf community themselves, and it's hosted here in Derby. And we're doing some brilliant co-production work just to raise awareness across the deaf community, produce resources in the way that they want those resources to be produced, and then helping them to lobby for reducing barriers to access, so about interpreter availability and things like that, so they feel much more included. But it's a great piece of work.
Thank you. Councillor Kerr.
We talked about the gap between the idea and the realisation and the mechanism in between. And clearly things like bridges and high buildings are some of the things that people's minds will go towards. Derby's just going through the process of its new local plan, which includes a new strategy on tall buildings. And clearly any buildings that are built will meet the standards for, the national standards for building construction and so on. But I just wonder whether there had been any discussion about things like the location of buildings, tall buildings, or any risk factors in tall buildings that were actually discussed as part of this, or whether there's still an opportunity to do that.
We did some work a couple of years ago with the structures team around access to the means to suicide, particularly looking at bridges, and we had firmed up our processes for reporting and for looking at sites. So we've got a good relationship with the structures team around that. And I know Sarah, to mention that Sarah Barker is clear, and the team is very involved. She's part of the suicide prevention partnership, and she takes that work into the structures team. So I would imagine, I'm aware of it through the work in bridges, but I would imagine she would be linking into the local plan.
I don't think there's a link there. Okay. I think you need to talk to the planning department and make sure that's a consideration of buildings over, 3 stories? Yeah. So we need to have that linked in some way.
Yeah, I'll take that. Thank you.
Thank you, Richard.
Yeah, this isn't a question, it's for Councillor Ashby and Paul. There was an initiative started by Public Health in the county called Trauma Informed Derbyshire, which is a network and access to free training resources to train anybody who wants it in trauma-informed practices. I think it's now been taken over by University Hospitals Derby, so I'll forward you an email, and I think you can access training, resources and materials as the first level, and then if you require specific training to the next level. So there is trauma-informed stuff out there at no cost currently.
Thank you, Richard. That's really helpful. And just, do you want to come in on that, James? One final comment at the back, please.
Yeah, thank you. There's still some training available as the resources on the Derbyshire Mind website at the moment. So I'd made a note to share the link afterwards, actually, with you all. So it is still there.
Thank you.
It's just a follow-up to the point that the Chair has made about the absence of female in in your work. I wondered if you have done any work to determine the proportion of people who make an attempt to suicide and those that are succeeding. The reason for that, it could be that we're not able to see men before they make an attempt. As a result, they are succeeding. And it could be that we are putting in intervention in place, because in my experience, the number of women who report to the A&E with suicide attempt is way above the level of men who report in A&E with a suicide attempt.
Yeah, I can respond partly to that. I think what we do know about suicide attempts are the majority of them are not reported at all. They are behind closed doors and they are unreported. So we don't know the true extent of what happens. I think some of the research has indicated that male and female are different in their support networks, in some of their protective factors. There is, I suppose, a growing evidence base that men who take their own life, as Alan mentioned in one of his stats, is that 2/3 to 3/4 of people are not known to mental health services. We know that males often exhibit no signs of emotional distress at all, and what we hear a lot from bereaved families is we never saw any signs. It was a complete shock to us. So there's something different around men in where they hold that burden and suddenly take the step, reach that step point to take their own life very, very quickly. So there's a lot, like I said, with the evidence base, it's not strong enough yet. We don't quite understand how we unpick that. So there's a lot of learning still to do around both genders, and the data can form a part of that. Again, the data is not strong around it as well, so a lot to go out.
Thank you. I think just to sum up that, I think that I don't think that anybody in the room thinks that there's a competition here, but there's clearly a sexual difference in the approach to dealing with these issues, which can cause suicide or attempts to suicide. And therefore, all I would stress is that if we're going to name men as men and address them as men in their psychological problems, if we're going to address women's psychological problems, we need to be not euphemistic and not scared about naming them as women, as the vast majority of them name themselves, and that's absolutely essential, I think, in many public health initiatives. But clearly, there's a sexual difference. It's not absolute. It'll be tendencies, and both matter, and that's clear. You know, the situation with men is absolutely distressing, but the particularities of women's situation is also problematic. So that's what we'd like to see. And I'm not going to invite you to come back on that. Thank you, James, because we're now at 10 past. But I'd like to thank you both for the work, and it is close to many of our hearts, as Alan knows, and we want to see, we want to help. Everybody wants to help. And so I'm sure, can I just assume that the room does take on board the recommendations as asked, as put forward by Alan? Thank you. Do we, Richard, I presume you're down to go through us on the mental update. Can we just note the Derbyshire Health Protection Board, or did you want to go through it? You're happy to just note it. So we'll just note that final report. And so with that then, we're only 10 minutes over time. That's unusual. I'd like to thank everybody for bringing really fantastic, excellent, really important reports this afternoon. And we'll see you next time. Thank you. Bye.